The Deep Dive, where we wrestle the most complex, evidence-based topics into clear, actionable understanding.
Hey there.
If you've ever felt that frustrating twinge in the back of your heel or calf or, watched a friend struggle to lace up their running shoes, today's Deep Dive is absolutely for you.
It really is. We are talking Achilles Tendinopathy, or AT.
And it's a huge topic.
It's a huge topic and one that, frankly, has been plagued by outdated advice for years. Achilles tendinopathy isn't just a minor ache that runners get.
Not at all.
No, it's a chronic, often debilitating issue that significantly impacts mobility, daily activity, and even, as our sources really emphasize, a person's sense of self, their identity.
Our mission today is laser-focused. We are cutting through all the confusion, what you should rest, what you should stretch, what you should push through.
Yeah.
We're unpacking an expert review on the physiotherapy management of AT, understanding not just how to treat it, but really why common treatments work, or maybe more often, why they fail.
And we are relying heavily on a recent, really comprehensive expert review from the Journal of Physiotherapy. And if there's one takeaway to hold on to from the very start, it's this.
Okay.
The field is demanding a necessary philosophical shift. We have to move away from a purely biomedical approach, just treating a painful structure.
Right, the broken part.
Exactly. We have to move to a much more integrated biopsychosocial model, where load management, the patient's fears, their expectations, all of that is just as critical as the physical tissue itself.
Okay, let's unpack this right out of the gate with terminology, because if we're going to talk about a scientific shift, we really need to agree on the language we're using.
Absolutely. The international consensus is clear. We use the umbrella term, Achilles tendinopathy, or AT.
Just AT.
Just AT. We need to standardize this because the older terms, they become really problematic.
So why are those older terms like tendinitis or tendinosis being actively discouraged now? I feel like you still hear those terms everywhere.
Oh, you do, and that's the problem. Tendinitis implies that the primary issue is inflammation. That suffix "itis" suggests, heat, swelling, an acute inflammatory process.
Sure.
And while there might be some inflammation initially, chronic tendinopathy just isn't primarily an inflammatory condition. It's more of a failure of the tendon structure to adapt to load.
So when patients hear tendinitis,
They immediately think, oh, I need a rest. I need anti-inflammatories. And they mistakenly believe those passive treatments will be enough for recovery.
I see. So the term itself actually steers the patient down the wrong path from the start.
Precisely. And tendinosis is just as problematic. It implies degeneration, simple wear and tear.
Which sounds pretty hopeless.
It does. It ignores the adaptive capacity we're actually trying to stimulate with exercise. So when these specific, often unclear biological terms are used, it just creates confusion, it delays active treatment, and most importantly, can dramatically reduce trust in the whole process. So if we keep it simple, keep it accurate. AT.
Understood. 8 it is. And we are talking about two specific anatomical presentations of this.
That's right. We primarily focus on two types. The first is mid-portion AT, which occurs 2 to 6 centimeters above the heel bone, the calcaneum.
That's the classic spot for runners, right?
That's the one. The second is insertional AT, which is right at the posterior calcaneum, where the tendon actually attaches to the bone.
And this is a critical point.
It's critical because the sources point out that most of the research we have, the vast majority of the literature, is focused on the mid-portion type.
So we have to be more cautious when we're applying that evidence to the insertional cases.
We have to be very cautious.
Yeah.
They're not exactly the same beast.
Let's move on then and establish the sheer scope of this problem. When I think of AT, I immediately conjure that image of an elite marathon runner pushing through pain. But the picture is so much wider, isn't it?
It is much, much wider, and that image of the elite runner is frankly dangerously incomplete. Yes, AT is undeniably common in running sports. Our sources cite that a significant 6 to 10% of runners are affected at any one time.
That's a lot.
It is. And when you look at the entire career of a middle and long distance runner, the lifetime prevalence is just staggering up to 52%.
52%. So half of all dedicated long-distance runners will deal with this at some point.
At some point, yes.
But that data, it speaks to high-load activity. What about the rest of us?
And here is the crucial data point that truly broadens the scope. This is not just an athletic injury.
Right.
When researchers analyzed general practice data in the Netherlands, they found 2 to 3 patients per 1,000 show up with AT. And a full 2/3 of those individuals, 66%, are not classified as athletes.
Wow. So they're just, regular people.
They're people whose job requires a lot of standing, or people just trying to stay active casually on the weekends.
So this is an everyone issue, a major public health concern that's just kind of masked as a sports injury. What about the demographic trends?
The incidence peaks dramatically between 40 and 59 years old.
Hmm.
And this is a fascinating period because it often coincides with people either dramatically increasing their activity, the new year, new me thing.
Or returning to exercise after a long time off.
Exactly. Or they're just experiencing the cumulative load of life coupled with other systemic risk factors.
And men versus women.
Equally affected. But an overlooked detail is that about 1 in 3 people report bilateral symptoms.
Meaning both tendons are affected.
Both tendons. And that high rate of bilateral symptoms, it strongly suggests that there are systemic factors at play, not just purely mechanical ones.
That immediately leads us to the causative factors and this idea of the load problem. If it's not purely repetitive running, what is the core mechanism that initiates this failure to adapt?
The consensus is firm. AT is fundamentally an overuse injury. The mechanism involves walking, running, jumping, basically anything that requires a rapid stretch-shortened cycle of the muscle tendon unit.
Let's be clear about that mechanism. That's the calf muscle and Achilles tendon acting like a coiled spring, right?
Yeah.
Storing and releasing elastic energy really fast.
Exactly. And that spring generates incredible forces. We're talking 5 to 7 times body weight per stride.
Wow.
Yeah, and up to 6% strain during running. Now, the human body is built to handle that, but the issue is the speed of change.
The sudden change. We hear this advice all the time, but it's so often ignored.
It's identified as the primary extrinsic factor, and it's the most common mistake people make.
Just doing too much too soon.
Right. If you rapidly increase your running mileage, or you suddenly introduce a ton of hill running, you're exceeding the physiological adaptive capacity of the tendon.
And there's a mismatch there, isn't there, between the muscle and the tendon?
A huge mismatch. The muscle adapts relatively quickly. It gets stronger in a matter of weeks. The tendon, though, being less metabolically active, adapts so slowly it can take months.
Oh.
And that mismatch in adaptive speed is what overwhelms the system and leads to injury.
So we give the muscle an upgrade, but the tendon is still running on the old software, and the system just fails.
That's a perfect way to put it. Now, for the insertional AT down at the heel, we have an added mechanical complexity.
Which is compression.
Compression, exactly. For insertional AT, compression of the tendon against the heel bone, the calcaneum, is a significant risk factor.
And how does that compression happen?
It typically happens in extreme ankle dorsiflexion.
So like when your shin moves way forward over your foot?
Yeah, imagine running up a really steep hill or going very deep into a calf stretch over a step. That angle increases the compression risk right where the tendon hits the bone.
So if the mid-portion injury is usually pure stretching and load failure, the insertional injury is stretching plus a mechanical pinch.
Precisely. It's rare for compression alone to cause it, but compression during that rapid stretch-shortened cycle seems to be a major antagonist for that specific location.
That makes sense. Let's move to the intrinsic risk factors. These are the internal, systemic things that moderate your individual risk. So if you're not an athlete, what makes you susceptible?
This is where we truly step into the biopsychosocial model, because the source lists several evidence-based predictive factors that are systemic, not just mechanical.
Okay.
Of course, a prior lower limb tendinopathy or fracture is a red flag, but then you look at the metabolic and pharmacological factors.
Like the use of fluoroquinolone antibiotics. Why that specific class of antibiotics?
Fluoroquinolones, which are powerful antibiotics, they have a well-documented, though rare, side effect of negatively impacting tendon collagen metabolism.
So it makes the tissue more vulnerable?
Acutely vulnerable, yeah.
Yeah.
To rupture or tendinopathy, often within weeks of starting the drug, it's a direct chemical risk to the tendon matrix itself.
That is such a critical piece of history that a patient needs to share with their clinician. What about those other systemic factors?
Yeah, we need to look for things like elevated LDL cholesterol or triglycerides, hypertension, and potentially female gender or perimenopausal status.
And why is that?
Well, we know that conditions like hypertension and hyperlipidemia, high blood fats, can negatively affect the blood flow and the microvascular health of the tendon.
Reducing its ability to repair itself.
Right. And similarly, perimenopausal status involves the loss of estrogen, and we know that estrogen plays a protective role in tendon metabolism and strength.
It sounds like AT is far less about a single mechanical flaw like flat feet or a tight calf, and much more about a whole system that's just struggling to keep up.
That is the core takeaway.
Yeah.
And it leads to a critical realization that defines the modern approach.
Which is?
Pathology often precedes pain, but it is only a weak predictor of pain onset.
What does that mean in practical terms for the listener?
It means you can have two people stand side by side with identical ultrasound images. Both show a thickened, disorganized, structurally abnormal tendon.
Okay.
One person is completely pain-free. They don't even know they have it. Remember, up to 50% of asymptomatic people have some pathology. The other person can barely walk.
So the structure is the same, but the pain experience is wildly different.
Wildly different.
Yeah.
You're saying the pain isn't necessarily coming directly from the structure being damaged, but from the system's interpretation of load on a compromised structure.
Exactly. I like to think of it as a wrinkled suit jacket versus a cut on your hand.
Okay.
You wouldn't get upset or fear rupture every time you moved your arm if you saw a wrinkle in your jacket.
Right.
Even though it's structurally abnormal.
Sure.
But if you have a painful cut on your hand, you protect it obsessively. The tendon pathology is often the wrinkle, the structural abnormality that doesn't dictate pain. But the patient's fear, their history, their metabolic state, that dictates whether that wrinkle feels like a cut.
That makes so much sense. And it sets the stage for the human cost of this condition, the profound burden. If the pain is decoupled from the pathology, the emotional tax must be huge.
It is substantial. The review emphasizes that the biggest consequence reported is rooted in the loss of identity. For many people, running, hiking, even just walking the dog is central to their social life, their stress relief, their self-definition. When AT prevents that, the impact is massive.
So it's not just physical discomfort. It's an existential threat to how they view themselves.
And the data quantifies this. A major cohort study found 89% of participants reported pain and discomfort. 66% reported a clear mobility impact.
And half on their usual activity.
Exactly. The economic cost alone is significant. 38% of participants reported reduced work productivity, which puts AT right up there with the burden of moderately severe knee osteoarthritis.
That's incredible.
When you factor in direct treatment and lost productivity, the costs were estimated at over 1,000 Australian dollars per person. This is not a trivial ailment. It's a long-term drain on both personal capacity and the economy.
So we've established that AT is widespread. It's often caused by systemic factors and changes in load, and it carries this huge personal burden tied to identity and function. That makes understanding the diagnosis and prognosis just critical for setting the stage for treatment.
Right. So moving into section 2, looking at the clinical approach. Given that imaging complexity, the sources stress that diagnosis has to be primarily based on patient history and clinical assessment.
Prioritizing the story the patient tells and how their body reacts to load.
So what are the clinical hallmarks we absolutely must look for in that patient history?
First, the pain location is paramount. It must be strictly localized, either in that mid-portion, that sweet spot 2 to 6 centimeters above the heel, or right at the insertional region. If the pain is diffuse or higher up, we're likely dealing with something else.
And the history should almost always point to that sudden change in loading we talked about.
Always. That or the introduction of a systemic risk factor right around the time the pain started.
And how do the symptoms typically progress over time?
It's a classic gradual progression. In the early stages, people report minor pain or stiffness upon weight-bearing after prolonged rest.
The infamous morning stiffness.
That's the one. Or they experience the warm-up phenomenon. Pain when they start an activity that kind of mysteriously disappears after a few minutes of movement.
That warm-up phenomenon is so misleading, isn't it? It tricks people into thinking they've stretched it out or fixed it, and then they push harder.
Exactly. The body is sending a clear warning, but it's so easily ignored because the pain temporarily goes away.
So what happens as it gets worse?
As the severity progresses, that warm-up effect just vanishes. Symptoms persist for hours or even days after activity, and eventually they severely limit activity. But the key provocation, regardless of the stage, is always those stretch-shortened cycle loads.
Okay, moving on to diagnostic testing and that imaging caveat. Since the history is so key, how do we confirm it physically?
The clinical hallmark is reproducing that localized pain with loading tests. This starts simply with a double-leg calf raise, then progressing to a single-leg calf raise or maybe a hop task.
And if the localized pain is reproduced?
That helps confirm the diagnosis of AT, and it also establishes the patient's baseline load tolerance, which is critical.
But those tests might be negative in less severe cases? or if the patient is really protective of the area.
Right, and this is why clinicians use progressive load tests, building up the intensity systematically.
So you're finding the exact threshold where the system starts to generate pain.
Exactly. We're looking for that threshold. This is a crucial assessment for treatment planning.
Okay, let's go back to the imaging enigma, because this is where the biopsychosocial model directly challenges old school medicine. We mentioned the high prevalence of pathology in asymptomatic people. Can we drill down on the implications of that 45 to 51% statistic?
This cannot be overstated. When nearly half of people walking around pain-free have tendon abnormalities or thickening on an ultrasound,
Yeah.
relying on imaging alone for a diagnosis is just,
Wow.
it's malpractice.
Wow.
If a person comes in with localized pain and we imaged their tendon, find a structural abnormality and tell them your tendon is damaged and thickened, we have inadvertently handed them a diagnosis that feeds their kinesiophobia, their fear of movement.
You're giving them a nocebo. You're creating this expectation that they have a fragile tissue.
Precisely. And that can drastically increase fear avoidance behaviors, prolonging the pain experience even if the treatment is mechanically correct.
So when is imaging indicated?
Generally, only if the initial recommended treatments fail after a long trial, say 4 to 6 months, or if the clinician needs to rule out some red flags or confirm a different diagnosis.
So what are those critical red flags? What should a clinician be thinking about?
Well, clinicians must screen for things like a frank tendon rupture, which requires emergency management. That's characterized by a positive Thompson test and a significant inability to plantar flex the foot.
And what else?
Another key screen is for suspected inflammatory arthropathy, like rheumatoid arthritis.
How would you suspect that?
You'd suspect it if symptoms are sudden, severe, bilateral, and happen without any obvious change in activity. Or, crucially, if the patient reports a poor response to even very low-intensity exercise. In those cases, the mechanism is systemic inflammation, not mechanical overuse.
Okay, so diagnosis is clinical, confirmed by provocation tests, and imaging is a late-stage tool. Let's address the elephant in the room. The clinical course and prognosis. If exercise works, why does this condition feel so persistent for so many people?
The clinical course confirms that without active management, the outcomes are poor. The sources note that in one trial, only 24% of participants who used a pure wait-and-see approach for mid-portion AT actually recovered.
Only a quarter.
Just a quarter. Exercise is the indisputable engine of recovery.
So what kind of measurable improvement can we tell our patients they'll see with a proper exercise intervention?
Exercise interventions yield an average improvement of 20 points in composite pain and disability scores over 12 weeks.
And that's a high number.
It's a very high number. It's well above the 14-point threshold that defines a clinically meaningful benefit. So yes, the evidence says exercise works, and it dramatically improves life quality in the short term.
But if exercise works so well in 12 weeks, why do we see such a high persistence rate over the long term? You mentioned 25% of people still have symptoms a decade later. Is it about adherence, or are these people truly treatment resistant?
That is the essential, challenging question. While further improvements do happen between 12 and 52 weeks, the benefit continues for a year, the data shows that persistence is incredibly common.
So what does that suggest?
It suggests a few things. First, adherence is likely a major factor. These programs are intensive, and life gets in the way.
Sure.
Second, it suggests that for that smaller group, the initial management might have missed the underlying systemic issues, the metabolic or psychosocial factors, which continue to drive pain signaling despite some structural improvement.
So we might fix the local problem, but if the patient hasn't internalized the biopsychosocial approach or addressed the fear, the pain just hangs around.
Exactly. And for athletes, you have the added pressure of competition. Recurrence is high, 27% among elite soccer players, especially if they rush back with less than 10 days of time loss.
And many of them continue to compete despite the symptoms.
They do, which means that time loss alone fails to capture the full impact of AT. We need to measure function and pain, not just days on the sidelines.
If the pathology is only weakly correlated with pain, and treatment is slow and persistence is common, then we clearly need a more comprehensive assessment. This brings us to Section 3, the biopsychosocial assessment. Let's start with load tolerance. How do we decide how much is too much?
Load tolerance is the key metric that guides everything: activity modification, exercise progression. We use it not just to avoid injury, but to build confidence. It's a dynamic assessment with three main components.
Walk us through those three pillars of load tolerance.
First, you assess the self-reported pain intensity during their specific loading activities, like a single-leg hop or running on an incline. That gives you an immediate snapshot.
Okay.
Second, and this is crucial, if the patient has a flare-up after an activity, you have to assess the time it takes for the pain to return to preloading levels.
Right, that recovery time is vital. If I run for 30 minutes and the next morning I'm back to my baseline, that's much better than if I'm limping for 3 days.
Absolutely. If the pain takes days to settle, you push too hard, the system was overwhelmed. The third component is assessing self-reported pain intensity during a progressive loading task, using a 0 to 10 pain scale.
And the guideline suggested in the literature is that pain rated up to 5 out of 10 is generally acceptable during the activity.
Yes.
That 5-10 rule often surprises people. We're basically normalizing some pain during the activity rather than demanding they stop immediately if they feel anything. Why is that acceptable?
Because AT pain is load dependent, it generally increases proportionally to the load, but we know the tendon structure itself is stable, even if it looks abnormal on an image. The 5-10 rule is a confidence-building guide for the patient to manage activity and fear.
It's not a rigid mechanical measure of damage.
Not at all. We are telling them this level of pain is safe. It means you are challenging the system, which is necessary for adaptation, but you aren't damaging the tissue further. We have to remember that pain is not a direct surrogate for load because of those other influences.
Right. So moving to assessing physical and functional capacity, if we're asking the patient to load the system, we need to know what deficits we're starting with.
The physical exam must include multidimensional calf muscle capacity testing, looking at both strength and endurance.
And what does the research say?
The research is clear. Maximal strength is often significantly more impaired, we're talking reduced by 16 to 44%, than endurance, which is only reduced by about 8%.
And we noted the necessity of looking beyond just the gastrocnemius muscle.
Yes, this is so crucial. The soleus muscle is the powerhouse here. It has a huge cross-sectional area, 3 times the medial gastroc, 6 times the lateral. It does most of the heavy lifting.
So you have to test it in different positions.
You have to. Assessment in both the knee straight position, which gets both, and the knee bent position, which biases towards the soleus, is absolutely crucial for a complete picture. If you only test standing calf raises, you might miss a huge soleus deficit.
And beyond raw strength, how do we assess that dynamic spring-like power?
We assess power because power impairments are very common in AT patients. We could use objective measures like submaximal hop height or performing single or triple hops for distance.
And this has to be done carefully.
Of course. These tests are essential for seeing if the patient is ready for the later stages of rehab, but they have to be done when pain is acceptable to avoid flare-ups.
You also mentioned looking for those adaptive load reduction strategies the patient might not even realize they're using.
Right. Clinicians should be vigilant for compensations. For instance, landing flat-footed instead of on the toes, or landing with minimal ankle absorption.
Kind of like a stiff landing.
Exactly. If they're a runner, video analysis might show reduced ankle dorsiflexion and misstents, a response to avoid load, or maybe running with a low cadence.
And there's a proactive intervention for that.
There is. The sources suggest increasing running cadence by 5% above the patient's preferred rate. This can actually reduce Achilles stress by limiting ground contact time and peak force.
Now we arrive at the heart of the modern management strategy, the biopsychosocial factors. These are the levers we pull when the pain is persistent, or when the physical deficits just don't explain the patient's suffering.
This is where we move beyond the physical exam and delve into the patient's history and their mental landscape. We already discussed the general health factors, cholesterol, hypertension, age, but we need to look closer at their story.
What elements in their story would indicate a potential psychosocial component?
A long duration of symptoms, multiple failed treatments, and very often inconsistent advice from a bunch of different clinicians.
Oh, it'd be so frustrating.
It leads to frustration and dramatically reduced outcome expectations. If a patient believes treatment won't work because 4 prior attempts failed, it's much harder to get a positive outcome.
And how does prior imaging, if it was done, feed into that negative belief system?
If prior imaging was perceived as showing severe pathology, that label alone can heavily influence their beliefs and behaviors. That perception links directly to the biggest psychological factor we have to address: kinesiophobia.
Fear of movement. This is a term we hear a lot. How do we objectively identify the degree of fear in the clinic?
Well, you can see it subjectively with their apprehension or unwillingness to complete loading tasks. But to quantify it, we use validated tools like the Tampa Scale of Kinesiophobia 11, TSK 11.
And what exactly does that measure?
It's an 11-item questionnaire that probes how much the patient believes movement will cause harm, re-injury, or rupture. It measures that fear avoidance behavior, which is a huge driver of chronic pain.
So what do the scores mean?
Scores generally range from 11 to 44. Minimal kinesiophobia is 11 to 22. But when scores climb into the high range, 36 to 44, that tells the clinician that the treatment strategy must be almost entirely dedicated to graded exposure and education.
To reduce the perceived threat.
Exactly. Because the fear, not the tissue, is the primary barrier.
That is a fundamental shift in focus, treating the belief system as much as the calf muscle.
It is. And the fear is often driven by these maladaptive beliefs. The idea that activity may lead to damage or rupture, or that they must rest and protect the tendon, we have to challenge those.
And on the flip side,
preliminary evidence suggests that high outcome expectations, the belief that the new treatment will help, may independently predict a better recovery. Confidence is therapeutic.
and finally, what about the actual pain mechanism? Can AT ever evolve into a centralized pain state?
Typically, AT is a local nociceptive pain state. It's localized, not widespread sensitivity. However, for those with long-standing or multiple failed treatments, the sources emphasize that central sensitization features may be present.
And if they are?
If those central features, like widespread sensitivity or pain that's totally disproportionate to the load, are identified, it necessitates mechanism-based treatment strategies that incorporate broader pain education and management techniques.
This shift from fixing a tight calf to addressing cholesterol, belief systems, and fear of movement is truly transformative. It explains why AT is so persistent if you ignore those psychosocial levers.
Moving into Section 4, this is where we put that assessment into action. The sources are absolutely unequivocal. The primary management starts with education and advice. This is the antidote to kinesiophobia.
This has to be the cornerstone of empowering the patient, right? If you don't believe your tendon can heal, no exercise program in the world is going to work.
Exactly. The primary goal of education is to empower the patient with understanding, to build confidence in the tendon's capacity, and enable effective self-management.
They want to know why this is happening.
They want to understand the cause, the pathology, and what is truly needed to overcome the condition, not just a list of exercises.
So it's about directly confronting the worst-case fears they walked in with, particularly the fear of rupture.
Yes. Education has to directly address fears of worsening the condition or, critically, fear of rupture. The evidence suggests that even in severe chronic tendinopathy, actual rupture is still rare. But we have to challenge maladaptive beliefs, like the destructive idea that rest is curative.
And the source suggests going beyond just talking.
Right, using engaging multimedia resources like the Tame the Beast or Why Things Hurt videos. This education beyond words uses visuals to reinforce the biopsychosocial pain model, showing that pain is an output of the brain, not a direct measure of tissue input.
And setting expectations seems incredibly important here, given that 10-year persistence data.
Realistic expectations are key for adherence and confidence. Explain that recovery means a return to activities, possibly with mild lingering pain.
Use the data.
Exactly. Show them that 60% may still have some mild symptoms at 5 years, and that while meaningful improvement takes about 12 weeks, full resolution may take 6 to 12 months.
That's a long time.
It is. But if the patient expects 100% pain freedom in 3 months, they will inevitably become frustrated and drop out when they're at 80% recovery. We are preparing them for the long haul.
Let's look at the evidence behind this education piece. Is pain science education truly superior to simply teaching anatomy?
One trial compared pain science education focused on neurophysiology and fear reduction versus control education, which was more about pathophysiology. The sources found low certainty evidence that there was no substantial difference in outcomes.
That's a surprising finding. If both groups got better at the same rate, what was the mechanism?
It suggests that the highly detailed content of the education might be less important than the common element they shared.
Which was?
Both forms of education included clear advice about acceptable pain levels with continued activity. That single message that loading the tendon with acceptable pain is safe and necessary seems to be what's crucial.
That ties directly into the advice about activity continuation. Should patients be forced to rest entirely?
A study compared continuing sport activity, if the pain was acceptable, versus forced cessation of sport for 6 weeks.
And the result?
The evidence, though low certainty, showed no difference in outcomes in the short term. But here's the kicker. Forced cessation resulted in worse physical function at 12 months,
Relative harm from forced rest. That's a powerful argument against traditional advice.
It is. Forced rest leads to deconditioning, increased fear avoidance, and a loss of functional capacity. The clinical takeaway is a strong recommendation. Continue activity within acceptable pain limits.
How does a clinician implement that philosophy in a tailored way? Let's talk about the activity modification strategy.
Modification is cited as the most effective strategy for managing pain in the short term. The decision to modify is entirely based on that load tolerance assessment we did.
When is modification necessary, and how much modification are we talking about?
When load tolerance is severely compromised, pain is consistently above 510, or flare-ups last for days, it is often necessary to remove those provocative high-intensity activities, like faster running or hills.
And reduce the volume.
Yeah, the general suggestion is reducing overall volume by about 50%. This is maintained for 2 to 6 weeks to allow the system to settle down and reestablish a baseline.
And for extreme cases.
For those extreme cases where walking itself is provocative, short-term, 100% cessation, or even using a walking boot may be necessary, but this should be measured in days or a couple of weeks, not months. The goal is always to reintroduce load as quickly as possible.
And finally, we have to tailor this advice for the patient's coping personality. You have the person who ignores pain versus the person paralyzed by fear.
We deal with two extremes. First, the activity endurance patient. Think of the hard-charging marathoner who sees pain as an obstacle to overcome.
Right.
For them, we need to clearly explain the rationale behind reducing volume and respecting the 5-10 pain scale, stressing that pushing past that is counterproductive.
And then the fearful patient.
The activity avoidance patient, often driven by high kinesiophobia, believes their tendon is fragile. For them, we use mandatory gradual activity exposure coupled with strict pain monitoring. We use their immediate feedback to show them that movement is safe and the pain is tolerable, reducing the perceived threat.
Tailoring the conversation to those coping styles is essential for adherence.
Now we get into the engine of tendon recovery, exercise. For years, Achilles treatment meant the famous Alfredson high-volume eccentric routine, but the field has clearly moved towards newer, more varied protocols.
So what are the key programs that dominate the current evidence?
The three key evidence-based programs are the classic Alfredson eccentric program, high volume, twice a day, every day. The Silbernagel program, which is more varied with eccentric moves and plyometrics, and heavy slow resistance, or HSR.
And HSR is gym-based.
Right. It's gym-based progressive intensity, moving from a 15-repetition maximum down to a 6-repetition maximum over 12 weeks.
Let's define HSR a little better. What does 6RM mean?
6RM means 6-repetition maximum. It's the heaviest weight you can lift for 6 repetitions with perfect form, but you couldn't possibly do a 7th. This is a very high, challenging load.
And it's necessary for adaptation.
It's necessary to stimulate adaptation in the tendon and increase maximal strength.
When we compare these three dominant programs head-to-head, is there a clear, definitive winner?
The evidence, while it's moderate to very low certainty, suggests that the Silbernagel or HSR programs are generally favored over the high-volume Alfredson program for global benefits.
Why are we moving away from the Alfredson protocol, which was the standard for so long?
It seems to come down to two factors: adherence and functional preparedness.
Okay.
HSR is high load, which is effective for building maximal strength. The Silbernagel program is more varied and gets you into speed and plyometrics earlier, which better prepares the tendon for real-world activities.
And the Alfredson protocol can be tough to stick with.
Incredibly time-consuming and painful, often leading to lower adherence.
What about the idea that eccentric training is superior?
That's being heavily questioned now. There's very low certainty evidence supporting its superiority, especially since many of the old comparisons were kind of unfair.
How so?
They pitted a very high-volume, daily eccentric program against a very low-volume, non-progressive concentric program. So the takeaway is heavy progressive loading is what matters.
So the clinical advice is to individualize the exercise prescription based on the patient's preference and what they have access to.
Exactly. Fit the program to the person's life, knowing that all these heavy load progressive programs are vastly superior to just waiting and seeing.
This leads perfectly to rethinking the exercise mechanisms. If different exercise types work comparably well, maybe we need to challenge the traditional view of why they work.
The traditional view posits that exercise works locally, that the mechanical stress physically disrupts painful nerve ingrowth or stimulates collagen synthesis and tendon healing.
Making the structure physically stronger.
Right.
But you're saying the research provides a major inconsistency here.
A huge one. Exercise does not consistently influence markers of nerve ingrowth, nor does it consistently lead to visible tendon healing on imaging.
So the tendon often looks just as abnormal after treatment as before.
Pretty much. And it also doesn't always lead to consistent increases in muscular strength, even though patients report dramatic improvements in their pain and function.
So if the tissue doesn't look structurally better, and the strength gains aren't always massive, but the patient feels functionally better, the mechanism has to be somewhere else.
It leads to a profound new hypothesis. Other non-mechanical mechanisms are mediating the outcomes. The most likely candidates are improved self-efficacy, the belief in one's ability to perform activities, and reduced movement-related fear.
So the exercise isn't just a tissue healing intervention, it's a confidence-building intervention, a form of exposure therapy.
That's the idea.
And this directly supports the 5-10 pain scale we talked about earlier. What does the evidence say about the role of painful exercise?
Low certainty evidence suggests that pain outcomes may actually improve in the short to medium term with painful exercise compared to pain-free exercise.
So telling patients it's okay for the exercise to be painful within limits.
It normalizes the experience. This active normalization positively impacts their fear of movement. We are using the exercise to change the patient's interpretation of the pain signal.
Okay, let's look at the structure of this approach, the graded exposure rehabilitation. This is the practical roadmap that ties it all together.
The concept is key. Exercise is graded exposure, progressing based on perceived threat and apprehension and the pain level. We're using the movement itself as an opportunity to reconceptualize the pain.
Starting with phase 1, isometric exercise. When do we use this?
This is the critical starting point. If isotonic exercise is unacceptably painful, or if the patient's kinesiophobia is extremely high.
And what's the goal?
The goal is simple. Find a position where symptoms are tolerable and hold a contraction, often for 30 to 45 seconds. This provides an immediate, safe, low-threat way to introduce load and reduce pain sensitivity.
It's a desensitization mechanism.
Exactly.
And phase 2, isotonic exercise, the main strength builder.
You start here if it's tolerable, or you transition as soon as possible from isometrics. Isotonic exercise is performed slowly. The source suggests a metronome at 60 beats per minute, aiming for 2 to 3 seconds each for the lifting and lowering phases.
And that slow tempo maximizes time under tension.
It does. And it allows the tendon to adapt to heavy load without relying on that springy, elastic energy storage.
What about progression?
Progression is crucial.
Yeah.
We have to progress to the full ankle dorsiflexion range because that's where the greatest tendon loads happen, and we need to rebuild that capacity.
Then phase 3, the stretch shorten cycle, the functional return.
This is the gradual reintroduction of dynamic, elastic activities, walking, running, jumping, typically 2 to 3 times per week. This phase carries the highest loads and the greatest risk of a flare-up.
So careful monitoring is essential.
Absolutely. We use objective data, running time, pace, step count to guide the progression, making sure we're not overwhelming the system.
It's a beautifully fluid process, completely driven by the patient's tolerance, not a fixed calendar schedule.
It has to be.
And finally, what about specific capacity impairments? If strength and power deficits persist after pain resolves, what are the high-level targets?
We must target maximal strength and power, because persistent deficits are known risk factors for onset and recurrence. So we use those higher intensity exercises, like the HSR protocols with lower rep ranges.
How does a clinician objectively monitor maximal strength increase in the clinic without expensive equipment?
Since a true maximal contraction assessment is often difficult and painful, we use a pragmatic approach, the OMNI scale. It's a rating of perceived exertion scale, 0 to 10.
And you target a high number.
We target an RPE rating of 8 to 9 out of 10 based on their comfort. This ensures they're working intensely enough to stimulate change without crossing that 5-10 pain boundary.
And those specific functional strength targets, the numbers the patient can aim for as proof of improvement.
For recreational runners, we have clear targets to achieve before they start maximal plyometric work. Specifically, getting to 1.5 times bodyweight 6RM in a seated calf raise.
Let's make sure everyone grasps the magnitude of that number. Why 1.5 times body weight and why seated?
The seated position specifically biases the soleus muscle, which is that primary powerhouse. We use the 6RM to test maximal strength, not endurance, and 1.5 times body weight is a crucial functional reserve.
So if you weigh 150 pounds, you need to be able to lift 225 pounds 6 times with your calf muscle.
You do. That high threshold provides the patient with tangible proof that their capacity has significantly improved. It builds confidence that they can handle high loads without fear.
And once that strength is developed?
Then we move to power development. generating reactive strength using progressive plyometrics landing, jumping, hopping, specifically tailored to their sport.
Now we shift gears to look at everything we add to education and exercise, the so-called adjuncts. Does adding a specific device or treatment actually move the needle further? Let's start with mid-portion AT.
The general advice here is straightforward and safe, recommending shoes with a pitch greater than 8 millimeters, avoiding flat shoes, and using simple heel wedges for short-term comfort.
In ice or heat.
In ice or heat, yeah, for temporary pain relief. These are fine for managing symptoms, but they are not the drivers of tissue adaptation.
What about the more intense or high-tech interventions? Let's tackle extracorporeal shockwave therapy, ESWT.
The evidence here is complex and nuanced. Low-certainty evidence suggests that adding radial ESWT to exercise may improve pain and disability, even compared to a placebo.
But not other forms of shockwave.
Right. Other forms focused or combined ESWT showed conflicting or no benefit. So if a clinician chooses to use ESWT, the radial form is currently favored as an adjunct to a primary exercise program.
What about other common treatments people spend significant money on, like night splints, laser therapy, or custom orthotics?
This is where we need to be direct. Low-certainty evidence shows that adding low-level laser therapy, an air heel brace, night splints, needling, or custom orthotics to exercise did not add benefit.
They didn't make the patient functionally better than exercise alone.
They did not.
Why do night splints fail, for example? They seem logical, stretching the tendon while you sleep to reduce morning stiffness.
They often fail because, first, compliance is typically really poor. People hate sleeping on them.
I can imagine.
Second, in chronic tendinopathy, the stiffness isn't caused by a short, tight muscle that needs passive stretching. It's caused by the tendon struggling to tolerate load upon waking. The mechanism is just flawed.
So exercise remains the gold standard, and most adjuncts simply don't move the needle much further.
Exactly. They may provide temporary pain relief, which is valuable for adherence, but they are not the primary driver of functional recovery.
Let's move to the nuance of insertional Achilles tendinopathy. This requires a specific modification because of that compression risk at the heel.
This is a critical distinction,
Yeah.
and it's based on a smaller body of evidence. First, there's a surprising finding regarding adjuncts.
Ooh.
Low-certainty evidence suggests that ESWT alone was more effective than exercise for insertional AT.
That's a stark contrast to the mid-portion findings.
It is. This may be because avoiding compression is so difficult in early exercise.
And that compression risk is the central management difficulty here.
It is. Traditional protocols, like Alfredson's, require exercising over a step into full ankle dorsiflexion. For insertional AT, this maneuver can severely increase compression and violently provoke symptoms.
So the key is limiting dorsiflexion early on. How do we achieve progressive loading while avoiding that painful compression?
Management advice in the isotonic phase must be to limit ankle dorsiflexion if it is painful. The patient should perform the calf raise on a flat surface, not over a step.
But the long-term goal is still to get that range back.
The long-term goal is a graded introduction of dorsiflexion as tolerated, because maximal tendon force is greatest in dorsiflexion, and we need that capacity back.
And there's a specific strategy for this.
The recommended strategy is to use custom-made small steps, 10 millimeters, 20 millimeters, 30 millimeters, to gradually progress the dorsiflexion range, based entirely on pain tolerance. We're teaching the tendon to tolerate compression and load simultaneously.
And finally, secondary management. If everything fails, good education, good adherence, multiple exercise protocols, what's the next necessary step?
First, we need to confirm adherence. If it's low, we extend the primary management period, maybe adjust the program. But if adherence is high and things still fail after 4 to 6 months of heavy, consistent loading,
Then what?
then the patient is referred for secondary management. This typically involves a sports physician for consideration of imaging, medication, injection therapies, or sometimes GTN patches. Surgery remains a last resort and is considered uncommon.
This deep dive has provided such a powerful synthesis, moving us far beyond the simple advice of just stretch it. We've seen that managing Achilles tendinopathy is really an exercise in shifting focus.
From a reductionist model of fixing a damaged structure to a comprehensive biopsychosocial model focused on graded exposure and the individual's full experience.
And the crucial role of education cannot be overstated. We have to empower the patient, address those fears of rupture, and normalize acceptable pain during activity.
That changes the patient's relationship with their symptoms. It turns pain from a stop sign into a guiding light.
And the management of load has become so much more sophisticated. We're moving away from a single, rigid protocol toward individualized, progressive, heavy load programs like HSR or Silbernagle.
The program is always driven by the patient's capacity and load tolerance, not by pain avoidance.
And despite all this recent progress, and it's important to note that most of the quality trials were published in just the last decade, we still have significant gaps.
We do. Future research needs include larger, more powered trials focusing on exercise and education for both the dominant mid-portion and the less studied insertional AT.
And I'm fascinated by that frontier of research focusing on subtendon function, how the different muscle components within the calf influence the pathology and treatment.
It highlights how much complexity still exists beneath the surface of these seemingly simple overuse injuries.
It really does.
And as we finish this deep dive, I want to leave you, the learner, with a final provocative thought that builds on everything we've discussed.
Okay.
We know that up to 50% of people without AT symptoms walk around with structural pathology on an image, and recovery often leaves people with mild, persistent symptoms years later. If pain resolves even when the structure remains abnormal on an ultrasound, the ultimate question is not, can we eliminate all pathology?
But rather,
Can we truly decouple tissue structure from pain and functional capacity for long-term health? And what does the concept of true healing mean if the goal is capacity and confidence, not a perfect-looking tendon image?
that is a question that challenges the core of modern medicine, and it is certainly worth exploring long after the initial pain subsides. Thank you for joining us for this deep dive. We hope you feel significantly more informed and empowered to navigate the complexities of Achilles tendinopathy.